I tell my patients the liver is a security gate. Anything comes to your body has really stopped, filtered by the liver before it gets in. That's what the liver all about, plain and simple. So just imagine if this liver is overwhelmed with fat and inflammation and scarring tissue, etc. Well, the security gate is going to be overwhelmed, not going to be able to do a good job. And some of the bad guys going to get into the system. And when toxins build up in the system, that's obviously going to affect the entire body. That's why liver disease is associated with increased risk of cardiovascular disease. Liver disease can put you at increased risk of diabetes, believe it or not. Liver disease can potentially affect your sleeping habits, may lead to poor concentration, may cause, believe it or not, dementia-like pictures because all of these toxins get built up in your body.
Hello, my friends. Welcome back to Better with Dr. Stephanie. It's me, your host, Dr. Stephanie Estima. And today we are talking all about the liver and the implications that the liver has to your overall metabolism and your body composition. My guests today are Kristin Kirkpatrick, who's a registered dietitian in the Cleveland Clinic Department of Wellness and Preventive Medicine, and Dr. Ibrahim Hanouneh, a medical doctor with a specialty in liver disease who previously worked at the Cleveland Clinic and the Mayo Clinic, who now sees patients and manages research at the MNGI Digestive Health in Minneapolis. What did we talk about today? Well, we started off with an overview of what the functions of the liver are. We need to know that before we kind of get into pathophysiology of it. So things like it being a metabolic organ, how it filters toxins from the blood. And then we start talking about when things go wrong. So what is non-alcoholic fatty liver disease? What are the origins? What are the root causes of it? Is it from having too much fat or potentially high ultra-processed carbohydrates? Like, where is it coming from? Why is it happening? And we talk about systemic inflammation that having a fatty liver can cause in the body and the relationship between that and PCOS and cardiovascular disease. We talk about metabolic syndrome and the 4 metabolic types that they outline in their latest book, Regenerative Health. So we talk about if you're healthy and lean, healthy and not lean, unhealthy and lean, and unhealthy and unlean, and what the action items are for each one. We talk about foods that are loving the liver, so foods that are great for liver function. We talk about this idea that not all sugar is bad. And when we're talking about foods that support the liver, which ones are they? How much should we be having? And what is the mechanism of action for improving liver function? If you are a woman in perimenopause or menopause, this is essential listening because this is where we start to see our blood lipids in perimenopause. We start to see our blood lipids go awry along with things like fasting glucose and insulin, et cetera. And then the other thing that we talk about, Dr. Hanouneh talks about is the lab ranges for metabolic, so the HbA1c and your triglycerides, etc. Action-packed, lots of actionable items in here. I hope that you enjoy this conversation as much as I had having it. So please enjoy my conversation with Kristin Kirkpatrick and Dr. Ibrahim Hanouneh. All right, and we're live. I am welcoming today Kristin Kirkpatrick and Dr. Ibrahim Hanouneh to the show. Welcome to you both.
Thank you. Thanks for having us. What an honor.
I am so excited to be speaking to you both today around metabolic disease, and specifically in the context of our conversation, we're going to be framing up liver health and how the liver functions, systemically, and of course, how when things go awry, how that can contribute to metabolic disease and cardiovascular disease and all of the things. As I was mentioning to you in the pre-chat, a lot of my community, we lovingly call them our Betties, who listen to the Better podcast. So our Betties are, perimenopausal, menopausal, noticing some changes in their body composition, of course, certainly their hormones, mood, affect, maybe seeing changes in their waistline. And I think that this is a really important piece to the puzzle. So let's just dive right in. First, one of the things that shocked me about your book is Regenerative Health that you both co-authored. One of the things that shocked me was that there was a graph in the book, as of 2022, 40% of the population have non-alcoholic fatty liver disease as of 2022. That is up from 1988, which was 5.5%. So what this tells me is that a large percentage of the population have fatty liver disease that is non-alcoholic in origin. So we're not looking at cirrhosing of the liver through excess alcohol consumption. And also, the other thing that you mentioned is that most people don't even realize that this is happening. I thought that that was shocking and quite scary. So my first question, what are some of the maybe early warning signs? And then, of course, some of the mid and late stage clinical signs and symptoms that we see in someone who has non-alcoholic fatty liver disease. So that can be, clinical symptoms that the patient might be presenting with in the clinic. It might also be body composition changes, physicality, that kind of thing.
Thank you for the question. And as you mentioned, fatty liver is very common disease. Before COVID, 1 in 4 individuals had fatty liver disease. Just think about number for a second, 1 in 4 individuals. Post-COVID, after the pandemic, the number has significantly increased. And now studies suggest that actually 1 in 3 people have fatty liver disease. So the number, depending on the study, has increased from about 25% to high 30, close to 40%, depending on the study and the geography, et cetera. So this is, number one, very common problem. If you think about that for a second, like I said, 1 in 3 people, 1 in 4 people have fatty liver disease. The second problem is that this is a silent disease. It doesn't give you symptoms, particularly early on. The only way to find out if you have fatty liver disease is to ask your dietitian or physician to get you screened for fatty liver disease, because it's a disease that does not have symptoms early on. Or in other words, symptoms can be subtle or non-specific. For example, some of my patients with fatty liver disease tell me just feeling fatigued, or maybe have a little bit of indigestion, or maybe have a little bit of pain on the right upper side of my belly. Non-specific symptoms that could be related to so many other things. Now, fatty liver disease at very late stage, when you already have a lot of damage in the liver, etc., at that point, it will give you symptoms related to liver disease. But, that's why we're here today. We don't want to wait too long. We want to find it at early stages.
There's two things that come up for me as you're talking. Is one, when I think about, the in that chart in the book, looks like the 1980s was sort of the first time that it was reported, and it was reported at about an incidence of 5.5%. My question is whether or not we're seeing, and I would assume that the answer is yes, but I'll let you elaborate on it. Are we starting to see this issue more in the younger population? I have children at home. Obviously, I'm raising boys, and I have to really fight against them going to, a Circle K or some type of like 7-Eleven or whatever after school to get whatever junk that all their friends are getting, who all happen to be like, there's a lot of kids in both my boys are 13 and 11. They're obese. Like a lot of kids are sort of, have like ectopic fat distribution, that sort of, excess adiposity centrally. So do we know if there's an increase? My first question is, do we know if there's an increase in children acquiring this non-alcoholic fatty liver disease?
Yeah, so we do have some studies that show that as early as 8 years old, some children are being diagnosed with this. Now, again, this really parallels and mirrors the huge influx of insulin resistance and type 2 diabetes that we're seeing in pediatric populations. So because the liver is so fine-tuned to blood sugar management, it is very possible that a child who is incredibly young will get this. Now, that's really problematic, obviously, for many different reasons. But the first reason is that this is a disease that is slow growing. And that's a real light bulb of positive news, right? You've got a lot of time to reverse this, even if you find it late in life. So that's the great news. But if you are a child that develops fatty liver disease, you have a long time to grow that disease into a phase that may no longer be reversible. And then you're really in trouble. So it's really about kind of how do we address this in a pediatric population? We can't really address it in terms of weight because it's really hard to talk about children and weight in that type of direct messaging. So instead, we use that messaging of health. But as you know, I'm a mom of boys as well. If you're not mirroring that in your home, if you're not doing what you're telling your boys not to do, they won't do it. So really, it really boils down, at least in my practice with dietetics, of counseling the parents more so than the child.
Yeah, I couldn't agree with you more. I think that sometimes there's a bit of and this is not any comment on parenting it's like if if it works in your family, like you have to make the decision that works the best for your family. And I do also notice a trend where, children you can't say to a child, go and be active when you yourself are sitting and binging
Right.
Netflix. Like you also have to be the example because they're watching, right? They're watching and they're mimicking. And I have my, I guess my 13-year-old is really now he's really into weights. Like I'm really into weights. I've always been into weights. So now he sees mom like doing the squatting and the deadlifting and stuff. And he's like, oh, actually I want teach me how to do that. Right. So he's kind of wanting to follow, and his father works out and all that as well. But I think that there's a certain amount of mimicry that happens. Like they're going to mimic what they see in their household as the primary sort of influence in their life. My second question around the prevalence of NAFLD is there, when we think about the difference between men and women, there are a lot of, easy things, Kristin, you and I were talking about perimenopause and, some of the differences between men and there's like some obvious sexually dimorphic, the reproductive cycle being one of them. But there's some other subtle ways that women and men are different, like different, sizes of certain nuclei in the brain. Even the liver has been shown to be sexually dimorphic in the pattern of release of certain hormones. So my question here is, do we know if there's a difference in terms of prevalence of NAFLD between men and women? So do we see a higher prevalence in men? Do we see a higher prevalence in women? Is it just across the board almost the same, or nobody's looking at that? What do we think that is, Dr. Hanouneh?
Yeah, I would say both men and women are clearly at risk of NAFLD. But direct answer to your question, women are more prone to NAFLD, particularly after menopause. As we get older, it's a little bit difficult to lose weight, much easier to gain weight. And obviously menopause does not help that situation. The other part, which is kind of interesting, it showed up in a relatively recent study, is that, generally speaking, NAFLD or fatty liver is a risk factor for heart disease, heart attack and stroke, meaning, if you do have NAFLD, you're probably at increased risk of heart disease. And it seems that's particularly true for women after menopause. So I would say, generally speaking, NAFLD is probably about the same in terms of the prevalence, men versus women, but it seems like NAFLD is a bigger deal in terms of cardiovascular risk factor, heart attack and stroke in women in particular. And that's probably related to, it's complicated, it's multifactorial, but the hormonal changes associated with menopause has a great role there.
Right. And, from my understanding, and either of you feel free to redirect me here, but it's that estrogen deficient sort of environment that happens in that postmenopausal time where we start to see that, prior to menopause, we see almost a cardioprotective effect for that women have in terms of the development of cardiovascular disease. And then as we lose estrogen, which is, can drop to and it does drop in the menopausal, phase down to 1% of what it once was. And so we start to catch up to the guys, right? We start to really catch up to the risk and the prevalence of CVD such that, 10 years post-menopause, I think that the risks are almost equated. Kristin, would you say is that a correct statement? Is there any nuance there? Anything that you like to add to that?
I think definitely correct. I mean, estrogen is so protective. This is why I think I get into a lot of conversations with my patients about, should I go on hormone replacement therapy, like weighing the risk versus benefits, types of things like that. But we do see a huge spike in not only cardiovascular disease, we also see mental health goes down when estrogen goes down. So depression, anxiety, that is another thing that we see. And we also see mismanagement by the body of blood sugar. So, estrogen going away is the worst thing that can happen to a woman. It is the reason why my patients sometimes come to me and say, I woke up and I had a belly and I've never had this before and now I can't get rid of it. Right. So it's just I woke up and I have a belly, all of a sudden I have a belly. Right. And I don't know where it came from. And I'm doing everything.
Yeah.
How many women have told me, I eat nothing, Kristin. I work out all the time. I can't get this belly to go down. And that has to do with estrogen. Right. But if we think about subcutaneous versus visceral fat, we know that once we get that belly fat, that is deep within near our organs, deep within the cytokine storm that occurs when we have fat surrounding our organs. So a lot goes wrong for women. And at that stage of life, unfortunately, it's not to say that we can't offset it with lifestyle and maybe some other things, but I think when we think about cardiovascular disease, which was your original question, I think the postmenopausal woman, it's like a perfect storm. Yes, it's cardiovascular disease, but it's also their sleep is impacted, and that impacts body weight and the risk of cardiovascular disease. So everything kind of comes in such a way that it doesn't work well for the woman anymore. And it's you kind of got to shift your thinking of what you're going to do.
Yeah. Yeah. Which is why, in part, why this podcast exists, because we're trying to serve some of these women and giving them some of the tools that you've outlined in your book and some, other thought leaders as well. So I'm so grateful to have both of you here today. So let's bring this back to the liver a little bit. In the book you talk, there's a couple of different analogies. One that I really liked was this idea of like the cluttered house, that when we think about what the liver does, because I think women, when they're thinking about body composition, they're thinking about weight loss and maybe that visceral fat, and I also want to talk about health promotion and salutogenesis and not necessarily about weight loss. And I recognize that most of my women that I care for initially come to me because they want the weight loss. So we're meeting our beautiful patients, where they are. And one of the things that you talk about is this idea that as your house gets more and more cluttered, maybe it's with the apparent blood glucose regulation, as you mentioned, or the estrogen levels are starting to drop off, or the insulin resistance that sort of sets in with age, and the poor habits, which we're going to talk about, that it becomes more and more cluttered and more difficult for the liver to do its job. So let's maybe just, for someone who's not familiar with the normal physiology of the liver and the role that it has in terms of our metabolism and maybe our body composition, to a sort of second degree or even tertiary degree. Let's talk a little bit about what the liver does in the body. And I know it's vast and we can probably be here for a couple of days really describing everything in detail, but sort of a top, 30,000 foot forest from the trees explanation in terms of what the liver does.
I tell my patients the liver is a security gate. I like the analogy of the liver as a TSA gate. Anything comes to your body has really stopped, filtered by the liver before it gets in. That's what the liver all about, plain and simple. So just imagine if this liver is overwhelmed with fat and inflammation and scarring tissue, etc. Well, the security gate is going to be overwhelmed, not going to be able to do a good job. And some of the bad guys going to get into the system. And when toxins build up in the system, that's obviously going to affect the entire body. That's why liver disease is associated with increased risk, like we mentioned, of cardiovascular disease. Liver disease can put you at increased risk of diabetes, believe it or not. Liver disease at later stage of fatty liver can potentially affect your sleeping habits, may lead to poor concentration, may cause, believe it or not, dementia-like pictures because all of these toxins get built up in your body. When you unload, the good news, fatty liver is reversible. And when you unload the fat from the liver, the security gate gets back, if you will. And the liver able to filter toxins from the body, and the symptoms get better or results. So kind of, that's a really quick snapshot of what's the function of the liver. It filters anything comes to your body. It's the first gate of anything comes to your body has to stop filtered by the liver before they get in.
Wonderful. Yeah. So filtering toxins from the blood, and you go through this in the book, but filtering toxins from the blood, as you mentioned, transferring those toxins or transforming those toxins so that they can be like kind of getting them ready for excretion, metabolizing and storing fat, carbs, protein, processing and storing and secreting glucose, metabolizing and storing vitamins and minerals, including vitamin A, which is important for your eyes, vitamin K for blood clotting, vitamin D, all of these different things that we, the liver is I always call the liver sort of like at the perimenopausal woman because she's like multitasking, right? Like the liver is always doing so many things at once. And all of our organs, of course, are essential, but the amount of work, like it is a workhorse. I've heard estimates of like, if we didn't have the liver, we'd be dead in like 4 minutes, right? Like the ability to produce, substrate for our cells is unmatched. So I think it's important just to have a quick overview in terms of why it's important. And maybe for my next question, Kristin, maybe I'll have you take it, is what are some of, and we've been kind of dancing around a little bit, but what are some of the reasons? So if we have sort of an understanding of normal physiology, let's maybe start to understand the pathophysiology of the liver and what are some of the reasons or the causes that will create a liver that is accumulating fat, that is now not able to filter toxins and able to, provide adequate substrate for the body.
So, we keep talking about this term NAFLD, and I think it's important to note that the liver organizations, the consensus here is that there is actually a little bit of an alternative nomenclature that has come out called MASLD, which basically indicates that this is a metabolic dysfunction type of disease. It has nothing to do with alcohol, which we have said already. So when we think about the things that put us at risk for type 2 diabetes, for insulin resistance, so if we're, again, speaking about women, that could be a high waist circumference. So if our waist circumference is over 35, it could be that our laboratory data does not look good. Our hemoglobin A1C is up. Maybe our hormone regulation is just not where it should be. Maybe our lipid panel is not where it should be. All of those things come together when we look at this nomenclature of MASLD of metabolic dysfunction. And when we have metabolic dysfunction, and we go back to Dr. Hanouneh's description of how the liver is pretty much like, it's kind of like the puppet that's like making everybody do their job. When we have metabolic dysfunction, it goes directly to the liver. And that's why we start seeing the liver try and go and heal itself. So it's trying to, I tell my patients, it's like when you get a cut on your finger, you can see the swelling, you can see all the cells coming in to do that. When that happens in the liver, what occurs is scar tissue. And over time, that scar tissue overtakes healthy liver cells. So that is really where we're seeing the emergence of non-alcoholic fatty liver disease. It is a dysfunction of blood sugar. I think that's a primary thing. I think that's one of the main things. But it's a metabolic dysfunction in general that then is impacting the liver because of the important role liver plays in metabolic health.
Yeah, and that's an important distinction. I like the metabolic associated fatty liver disease nomenclature because I think that it's very easy when you hear non-alcoholic fatty liver disease. You're like, oh, fatty. So maybe I should avoid fat. Maybe it's the fat that's causing the liver to become fatty. And I think that can cause, I think it can cause some confusion in the same way that, we talk about cholesterol, like good cholesterol and bad cholesterol. Well, actually cholesterol is just cholesterol. It's just the carrier protein where that has, maybe more of a propensity. So I say this because we sort of joke on my team that there's like light roast Bettys and dark roast Bettys. Like the light roast Bettys don't want any of this detail, but there are some dark roast Bettys that are like, give me every single nuance. I need to know every pathway. Like they're like the super nerds. And so I think that it's important to understand when we are talking about something like metabolic associated fatty liver disease that I think when we look at some of the main, fats, proteins, carbohydrates, and we'll get to all of those, it's not necessarily that fat is the culprit. It's the overconsumption, I would say, of all types of foods. But when we talk about insulin resistance and sort of how that changes as we age, we can also look at the consumption of, let's say, ultra processed carbohydrates, sugars, or carbohydrates that are not paired with fiber. I'd love for you to expand a little bit on that in terms of what happens when we are consuming, let's say, excess carbohydrates and then again, with that nuance for my dark roast Bettys, what are, all carbs are not created equal, just like all fat is not created equal, all protein is not created equal. So let's talk a little bit about what happens when we are over consuming these ultra processed foods that are highly palatable that we tend to over consume and with more calories consumed.
It's so interesting. When I present, I have this slide and I took it from iStock, and I think I went to iStock and put in like healthy diet, right? And it's a picture of a woman and she's holding a smoothie and she's looking at a salad, and then she's putting her hand like, no, to the donut that's on the right. And what I always say to this picture is, this is the most unrealistic picture on the face of the earth, because the salad does not have the hyper-palatable characteristics that the donut does. We might love salads. We might look forward to a salad we're going to have in the evening, but we don't crave it. We don't think about it all day long. We don't wake up at night and think, oh my gosh, I would love, a salad right now. we do for the donut. So it's an unfair comparison. And I think I say that because we need to give ourselves a break. If we go back to this concept of good carbs versus bad, if we use that word good and bad, I like to look at what I call competition for digestion. So anytime you have a carbohydrate, I want there to be a lot of competition for digestion within the body. So an example would be if you have a piece of licorice, the body is like, hey, this is awesome. I love this sugar, and I'm going to your neurotransmitters are going to go up. You're going to be feeling that high. And when you feel low, you're going to want more of me. So you're going to go right back to getting more of me, right? And you can have, let's say, 1,500 calories. You got king size licorice at the movie theater and then head out and go grab dinner. You're not full. But competition is, now I'm going to have an apple, and the body's like, oh, I love this sugar. But there's also something else in here. There's insoluble fiber. There's soluble fiber. That's not digestible. I don't know what to do there. So now I got to figure out what to do with these guys, and that slows the absorption of sugar into the bloodstream. It's not just a free pass, right? You got something else to deal with. So that's competition for digestion. So even though some of the suggestions in our book are really looking at modification of certain carbohydrates, what we are really trying to hone in to all of our readers, but especially women, is if we get competition for digestion, we are probably making the right decisions about which carbohydrates to consume. If we have fiber, we are probably making the right decisions. Ultra-processed foods never start as food, but they don't end up looking like food either. So if they have fiber in them, it's probably an attempt to simply increase those numbers to make the nutrition facts panel look good. And most of the time, they're not going to see that anyway, right? So I think that's the key factor here, is that if you're going to have a carbohydrate, have one that takes your body a really long time and real difficulty to break down. Make it a hard to digest carbohydrate versus an easy to digest carbohydrate.
Yeah, I love that point. And I think, I'm a stickler for words, and, I'm glad that you use ultra processed, because most of the foods that we consume in some capacity is processed. Yep. Like even the chicken breast that you're buying, like that's been processed. Yep. Like someone had to cleave the pec muscle off of the chicken and then, process it and put it in a package or whatever for you to buy. But it's the ultra processed, it's the donut, right? And I was, as you were describing the iStock photo, I was like, for sure the girl is laughing if she's looking at her salad. I don't know what it is with
to make this decision.
She's so happy she's so happy.
There's almost an arrogance about
why
it.
That is. Yeah, exactly. But I love the idea of, okay, so we are all eating some, like it's a continuum, right? We're all having some kind of processed foods, right? We're not farming. We don't own farms. We're not like killing the animals ourselves or taking the berries from the blueberry bush ourselves. Like there is some processing that happens, but it's the it's usually the combination of it's those bliss points of foods, right? It's like the fats and the carbohydrates together, the donut, that are going to cause the overconsumption, because it's, there's been some theories like is it the protein leverage hypothesis? Like you're going to just continue to eat until you get enough protein and fat in the so you can have the donut, but there's almost like there's this much protein in it. So you're not really going to be satisfied, right? And then of course the bliss, you mentioned the neurochemicals like the dopamine, the serotonin, all that stuff that is released when you have the fat and the sugar together. Yeah. As you mentioned, are going to cause you to sort of seek out more of that because it is so good. It tastes so great. A donut tastes amazing. Let's just call a spade, right?
And I think it's a really important point you make about the combination of things, right? Like it always has to be a combination of two different factors. So like the example I give is if you took a stick of unsalted butter, you probably are not going to sit there and eat on it. Right? You're not going to chew it, even though unsalted butter tastes really great. Right. Where it really shines is when you put it on a piece of warm bread.
I was like, on a piece of
bread. Exactly. So now you've created that hyper palatable environment that didn't exist simply with having the butter alone. So, and that's a great example because butter is very satisfying. It's very good, but we wouldn't sit there and have a stick of butter, but we could have a whole stick with the right bread. If it's warm, if it has all those characteristics, that reels us in.
You both talk about this in the book, that the idea, so when we're talking about this metabolic associated fatty liver disease, I'll probably just call it NAFLD just because that's the nomenclature that I'm used to, but what's the short, how do you say it? MAFLD? Is that what you're, with an M? M-A-F-L-D?
MASLD. Am I wrong, Ibrahim?
What is the,
Yeah, no, correct.
is it what does it stand for?
Metabolic dysfunction associated steatotic. So S stand for steatotic, which is kind of, the medical term for fat. But to your point, like, we don't want to confuse people and use the word of fat. So that's why they replace it with steatotic as liver disease. So muscle.
And my question, Dr. Hanouneh, is for you. So, what we're talking about here, essentially, obviously the liver doesn't work in isolation as much as we would like to sometimes in medicine believe that that's how things work. Like the liver obviously connects to all of the different systems. And so when the liver is not functioning in the way that it should, we're going to be, this sort of systemic inflammation. We're going to sort of see the systemic inflammation. And of course, in men and women, that might present in a couple of different ways. Particularly for women, I wondered if you might elaborate on the link between, let's say, polycystic ovarian syndrome and metabolic and sort of a non, or I'm just going to say NAFLD because that's just how it is in my brain. I apologize. I'll have to update my operating system. But how is that associated with NAFLD, non-alcoholic fatty liver disease?
So polycystic ovarian syndrome or polycystic ovarian disease, as the audience know, it's quite common in women, obviously, and it's very connected with fatty liver disease. It turns out in some studies, up to 70% of women with polycystic ovarian syndrome have fatty liver disease, NAFLD or NASCENT. And the reason why, because it turns out polycystic ovarian syndrome, they tend to have insulin resistance. What's insulin resistance? Well, it's, as the name implies, it's resistant to insulin, meaning insulin is trying to do its job and lower the glucose, lower sugar, and get sugar into the cells. I'm unable to, facing really resistance. So insulin resistance is quite common in polycystic ovarian syndrome, and that's technically the cornerstone for fatty liver disease. When insulin is unable to do its job, the pancreas going to secrete more insulin. Insulin going to goes up in the system, and that's technically will lead to fat deposition in the liver, will lead to fatty liver disease. So the point is that every time I see someone in my clinic with polycystic ovarian syndrome, fatty liver disease, until proven otherwise, I tend to screen them for fatty liver. I want to make sure they've been followed closely, pay more attention to their diet, get some testing to find out the degree of their fatty liver disease, whether they have any inflammation or scarring of the liver. The connection is very strong between these two conditions.
So let's talk about the different types of, or the different metabolic types that you both outline in the book. And I'd love, you mentioned labs and waist circumference. I think this is a really great time for us to sort of delineate between the four different types, the waist circumference that we might be looking at. And then of course it's, we want to label them, but then also what are some of the action items that we might think about? So Kristin, let's start off with the first one, the preventer. Mm-hmm. So this is where we almost have like a bit of a rubric here. So we have healthy and lean, and then we're going to move to healthy and non-lean, unhealthy and lean, and then unhealthy and non-lean. Yeah. So let's start with the first one, preventer, healthy and lean. So what is the characteristics of someone who falls in this metabolic type?
So healthy and lean, let's number one define what lean and healthy, and we could figure out what unhealthy is by that definition as well, right? So lean is going to be defined as having a normal waist circumference. So for a woman, that's going to be 35 inches or less. Why did we go with such a strong stance on waist circumference with all of our metabolic types? Because we know that BMI is a flawed number. We know that BMI only tells some of the story, but it doesn't really tell someone's health. I've been a dietitian in integrative medicine at Cleveland Clinic for 20 years now. And for most of my career, I would go into the electronic medical record and I would look at what's the designation of my patient. And it would always be based on BMI. Right? Okay, this person is obese. This person is underweight, right? But it doesn't really tell the story of health. So healthy and lean means that person's waist circumference is normal. Okay, so that's the lean. And then healthy means their metabolic numbers are also normal. So your lipid panel's normal. You don't have sleep apnea. Your hemoglobin A1C is normal. So your labs look good, and so does your weight. who is the preventer, right? So why do we even mention this person? Well, we know that there's some genetic indicators for looking at non-alcoholic fatty liver disease. So this could be someone who has a very strong genetic background for type 2 diabetes in the family, for someone who's had fatty liver. Maybe their mom had fatty liver when they were in utero. That makes them more prone to developing the disease as well. So it's not someone who has to go as hardcore as the Regenerator. That's going to be on the opposite end. But you want to keep an eye on this. Maybe you do watch your drinking. Maybe you do make sure that you're getting enough color in your diet, enough plants. So that's how we define the first one.
So I just want to say I'm so happy that we're not all using BMI, because we know if you're someone who's putting on muscle, as I am, and as I'm hoping that my Bettys are, like that's also going to skew your BMI because muscle weighs more than fat. I tend to look at FF, like fat-free mass index. That's sort of because that's sort of taking into account your muscle. But you mentioned lipid, HbA1c. We've mentioned fasting glucose a little bit. Just can you give me some ranges? Are there ranges that you look at, or is there like an optimal range that you're trying to get patients in, or is this going to be bio-individual? I just wanted to ask that before we move on to the next metabolic type.
So I will let Dr. Hanouneh add to this as well. But for me, if all the numbers are normal, the only place where I might be a little bit more put someone in the next type would be if the hemoglobin A1C is on the verge. So if you are like a 5.7, a 5.6, you're not quite pre-diabetic, but you're 1 percentage point from there, and this is a 3-month marker of blood sugar management, then I might go a little bit more aggressive. Probably isn't the right word, but that's the blood sugar is what, as a dietitian, I'm looking at the most to determine what's going to be the best option for you, much more than the lipid panel for me. So even if your LDL is high and your HDL is low, but your blood sugar is normal, I'm probably going to take a little bit of a different approach. But I'll let Dr. Hanouneh speak to that as well.
Yeah, remember we mentioned earlier metabolic dysfunction. This is a disease associated with metabolic syndrome. So what's metabolic dysfunction? How do you know if you do have metabolic dysfunction? Well, number one, we mentioned the waist circumference. But the second part, to answer your question, there are really 4 factors. Factor number 1 is blood pressure, and we like it to be less than 120/90. Number 2 is glucose, sugar. And we like fasting glucose to be less than 110. Or, like Kristin mentioned, hemoglobin A1C, which give you an idea about blood sugar control over the last 2 to 3 months. We like it to be less than 6%, ideally. So that's number 2, sugar. Number 3, triglyceride. Not cholesterol, but triglyceride. And we like that to be less than 150. And then lastly, HDL, which is, as mentioned earlier, it's kind of, the good cholesterol, HDL as the good cholesterol, even we don't necessarily, I don't like the term good and bad, but anyway, that's HDL, the good cholesterol, and we like it to be high. You want the good one to be high. We like it to be more than, 40 for men and 50 for women. So we like that number to be high. And so those are the numbers, the kind of, the objective number we look at in addition to waist circumference. It turns out if you have 3 out of 5, including the waist circumference, and then you have metabolic dysfunction. If you have 3 abnormal tests out of 5 of the mentioned, then you have metabolic dysfunction.
Okay, great. Yeah, because I remember running especially for HbA1c, I remember running the numbers like 5.2, I think translates to 100 mgs per deciliter. Like that's still, like for me, that's high. I feel like, 100, I know the pre-diabetic is, I think it's 126 or like under one, and maybe you can redirect me here. I think it's 126, but I always like everything under 100. Like I like it 80 to 100. And maybe that's just me being a stickler for numbers, but yeah, like 5.6, like that's, like we're already dealing with some dysfunction in the body, right? So, okay, so super appreciate you adding some color there. So I interrupted you, Kristin. So we did the preventer, which is healthy and lean, and then the fine tuner, healthy and non-lean. So what does that mean? And then we can get to recalibrator and regenerator.
So that means that your waist circumference is higher than normal, higher than where we would like it. So you're carrying some belly fat, right? Because that's the other thing with waist circumference. We are looking at where the fat is most metabolically active. We're not looking at the fat in your butt area, your thighs area. That's not as active as when we have it in the midsection, right? Which is close to organs, things like that. So your waist circumference is too high, but your numbers are not indicative of poor health. So your numbers, your glucose, all those numbers that Dr. Hanouneh just went over all look normal, within normal range. So again, because of the waist, we'll go a little bit more aggressive than we would the preventer, but we're not going to go, as much as we would someone who has everything going wrong.
I want to play devil's advocate for a moment if I can. If someone has, let's say they would be a fine tuner. So let's say someone has a waist circumference that's 35, let's say inches, but their waist to hip ratio is about 0.7 or 0.8. Would you still consider them a fine tuner? Do you care about the waist to hip ratio, or is it just the absolute measurement of the waist that we're looking at here?
I do look at waist to hip ratio, and that is really where we're getting into the personalized nutrition approach, right? So like for our patients in integrative medicine, we go very deep into all aspects of measurements. For us, for the book perspective, it was easier just to focus on waist versus the height, the waist to hip ratio. Right. But yes, we would look at all those factors, and we would look at other things that actually go along with their lifestyle, right? Are they someone who is living in a area that has a lot of pollution? Are they sedentary? There's so many factors that go into this, but this is kind of the dirty nitty gritty of, all right, let's look at these things, and then we can choose which plan you go into. We're also very clear that your metabolic type doesn't have to dictate the plan you're in, right? The plan you're in, you could go in and out of plans, and you can determine what works for you based on your personal preferences, what you can sustain long-term. So again, as humans, there's really no one size fits all. And that's true for our plans as well. There's not one plan that goes with each and every aspect. There is that individual, that personalized approach that is so important.
I love that. Awesome. All right, let's do the next two. So we did preventer and fine tuner. Now we're in unhealthy and lean. So this is what you've called the recalibrator.
So this is someone who might come and say, I am skinny fat. All right. So I hear that a lot. Oh my gosh, my numbers are all over the place, but yet hey, I'm still a size 6. Or the scale still tells me I'm healthy, but my numbers don't, right? So this is kind of addressing, okay, how do we define health? And as everyone on this call knows, the FDA has yet to define health, right? We're still waiting for them to do that. They will soon. But we don't have a definition really of health, good health. So really, this is looking at, all right, well, if your numbers are not where they should be, whatever that means, even though you can still get into the same genes you had in college, does that mean you are healthy? So that's where we really get into those conversations there, and then maybe look at an even more aggressive plan than we did for the person whose waist circumference was high versus the person who's not high.
These are the TOFIs, right? These are the thin on the outside, but relatively fat on the inside, even though I think that's a terrible name. But yes, and we often find that I'm part Arabic, so we often find our Asians, our beautiful Asians, Indians, people from Pakistan, and through the Middle East as well. You can be sort of thin, like the size 6 to your point, but your lipids are a little wonky. The blood glucose is out of range, that kind of thing. So that's something to be considered as well. The last category that you outline in the book is called the regenerator. So now this is unhealthy and not lean or unlean. What is that? And then maybe we can spend a little bit of time on this category specifically in terms of what we might think about doing about it.
So we go into the fact that you've got those 3 factors that Dr. Hanouneh described. So you've got the high blood pressure, or maybe your LDL is high, your HDL is low. So you have 3 of the factors, and your waist circumference is over 35 if you're a female, and then over 40 if you're a male. So your waist circumference is high as well. What are the things we do here? I mean, this is really where we're going to look at someone who's most at risk for insulin resistance, for PCOS, and of course, because of that, for non-alcoholic fatty liver disease. So, we really, it doesn't really matter how at least in my practice, how we position the conversation. Well, we don't have to say, let's look at a fatty liver diet. We could say, okay, let's look at a diet that is going to be the best for lowering inflammation, because we know that we've got inflammatory factors going on with that type of environment, and what's going to be best for better blood sugar management. So that's really the conversation that we can start based on that last metabolic group. And we know in this group, okay, we know that we have to focus on gaining more muscle. We know we have to focus on lowering the waist size. We know we have to probably focus on improvements of diet. But that is the place where when you are sitting across from your dietitian or your physician, okay, let's talk about what works for you, right? So even just, hearing you, Dr. Stephanie, talk about being, thinking about being Arabic, like one of the things that we see in the studies is that if you don't adhere to cultural, religious, and personal preferences, it doesn't matter what diet I prescribe to you, you'll never follow it long term. All right, you'll follow it short term.
It's hard.
Follow it short term. It's the food you love, right? I mean, I'm Hispanic.
Yeah.
So there's very different foods that I may have had growing up than you did, right? And I don't want to give those foods up.
Yeah.
So how do we weave that conversation in with our patients about, hey, you can have these foods every once in a while. We're not saying never have this particular food. Let's look at what works for you and what you can sustain today, tomorrow, and 5 years from now.
I mean, I think that's the whole point of this. That's the key nugget for this whole show. It's like the diet that's going to work for you is the diet that you most enjoy doing over a long delta. It's like you're going to, maybe there's something that your grandmother cooked and when, you smell it, it conjures up, thoughts of when you were younger. I certainly have those foods on both my mother and my father's side where there's, you give me Lebanese food and I'm just like putty in your hands. Like, I just love it. Right. But that's also the, making sure that we can integrate some of these foods that are, as you were saying, that are culturally appropriate, certainly around religious holidays and all of that, like that all really matters into our enjoyment of life. And that's really the best prognosis that you have. It's like, it's the same with an exercise program. The exercise program that works for you is the one that you enjoy doing. And then you can do it consistently over a long delta. That's the one that's going to work, right? I'm always asked like, what's the best program? And what is it that you do? And it's like, well, I do the things that I love. I love to squat. I love to pull up. Like those are the things that really give me a lot of pleasure in the gym and I enjoy doing them. But someone might have like, I don't know, bunk shoulder or a bad hip or something, and they're not going to enjoy doing those things as much. So we have to think about what are some of the, things that bring you a lot of joy. And in this case we're talking about in the food realm, like what are some of the things that you love to eat? And then how can we maybe make some tweaks? Maybe the portion size is a little, that's usually a really big deal. It's like portion size, but then maybe it's not so much rice with kibbeh, right? Or like, in my case, like it's like rice with like a skewer of meat, let's say on top of it. Maybe it's not all maybe it's just the kibbeh or maybe it's just some grilled vegetables on the side. Like that's also very sort of adhering to sort of the cultural.
And we can look at how often you have them as well, I think. I think that's an important factor. I had someone ask me the other day, in Dominican Republic, we've got tostones and they're platanos and they're fried and they're delicious. And someone said, well,
they're delicious.
How can I make a baked tostone? And I'm like, oh, you can't. You have to deep fry it. That's what a tostone, I mean, you can, but it's not going to be the same. But the thing is, it's not when you have the fried tostone 10% of the time. You have it once a week. It's when it ends up on your plate every day. Right. So it's not the 10% of the time.
Yes. Oh, that's such a good point.
So it's like, okay, so like if you want to have donuts with your kids on Sundays, have donuts. Right. But you're having it on a Sunday. You're not having it every day for breakfast. So I think we need to that when I say give ourselves a break, we need to consider that it's part of how we define a healthy relationship with food. The 10% bucket is not really going to impact your health if the 90% bucket looks really good.
Yeah, that's such a great point. And I would argue that the 10% actually allows you to stay compliant the 90% of the time. Because if you're always on a diet, like that's also psychologically very, very difficult.
Yep.
I've run a program for women on sort of a female-centric ketogenic diet, which supports what we're talking about here in terms of improving insulin sensitivity and dropping adipose tissue, et cetera. And it's hard to adhere to long term because it's, you sort of ride the area under the curve, so to speak. Like you get sort of maximally the benefits in like 2, 3, maybe 6 months maximally. And then after that, it's like, I just want some carbs.
Yeah.
Like I
want a piece of bread.
Carbs. I want a piece of bread. And I think that there's something really important around recognizing that you can have a therapeutic intervention of something and know that it's temporary. And then you can, like, there's no bad foods, like the donuts that you said on the Sunday, the fried, churros or, whatever. Like all of those things have a place in the diet. And I think that adds to the pleasure and the prognosis really of whether or not a patient's going to be successful on a program or not.
Yep.
Okay, so let's maybe talk a little bit about some of the things that we can do to support the liver, because it's all up until this point, it's like all doom and gloom. We have a fatty liver, we have a waist circumference that isn't, going the way that we want, or maybe our lipid panel is not the, ideal, etc. But the good news is, and I've heard both of you talk about this, is that the liver is regenerative, that we can absolutely reverse some, especially if we're catching things earlier, in the earlier stages of things, that we can reverse our metabolic syndrome. We can reverse this fatty liver disease phenomenon. So what are some things that are within our control in terms of how we might think about reversing this degenerating condition of the liver?
Sure. I'll answer the question, but just to your point about regeneration, and for the audience, it's quite fascinating that the only internal organ that regenerates in our body is the liver. And I'll give you a little bit of kind of, a medical fact to support that. When we do live donor liver transplant, we take a piece of a liver from a loved one and give it to a patient who need liver transplantation. If you scan the donor and the recipient only a few weeks after the surgery, just a few weeks after the surgery, the liver is back to the original size in both donor and the recipient. It's almost like science fiction. I mean, there is no other organ outside the skin that does that kind of regeneration other than the liver. So because of this power of regeneration, the liver is resilient. Technically, if you find fatty liver disease, like we said earlier, at early stages and get rid of the fat, the liver regenerates, and the rest is history. So how do you regenerate the liver? Well, one kind of, mentioned already the diet, the low carb diet. Remember the name fatty liver is misleading. People think if I eat fat, I'm going to get fatty liver. It turns out what if you eat carbs, particularly the bad kind of carbs, you will get fatty liver. So number one would be cut back on carbs. We discussed this in our book about the moderate carbs intake or low carbs intake, depending on your metabolic profile. And number two, exercise. And there was one study came from Australia that they looked into specifically interval training. And, any exercise is good. Walking outside, we mentioned in the book, walking at Costco, even, that kind of light exercise works for fatty liver. But really, if you really want to get rid of the fat and burn the fat in the liver, you got to do a little bit of interval training. The study from Australia, they mentioned about 15 minutes, 3 times a week. We're busy. We don't have time to go to the gym every day, etc. The study support interval training, 15 minutes, 3 times a week, where you jump in on a standing bike or a treadmill, and you go fast to, burn the fat in your liver, get the heartbeat up, get the sweat going, slow down. When you're ready, go up again, 15 minutes, 3 times a week. So that kind of exercise turns out to be very beneficial for fatty liver disease. If you mix it with light workouts such as walking, etc., I think it would be very useful. And lastly, what supplements? I get this question all the time. What supplements, like, or herbs or stuff like that I could take to fix fatty liver disease? Well, believe it or not, there is not much out there. And the only supplement that has been proven over and over to be beneficial to fatty liver would be coffee, black coffee. You want to try black as much as you can. Once you start mixing coffee with the cream and sugar and other things, the benefit may go away. 2 cups of coffee every day, it turns out to decrease the inflammation in the liver. It does have anti-fibrotic effect. It may helps the liver get rid of inflammation. It does have anti-fibrotic effect. It may helps the liver get rid of the fibrosis, which means scarring tissue in the liver. The fibrosis, which means scarring tissue in the liver. So I always tell my patients to try the fibrosis, which means scarring tissue in the liver. So I always tell my patients to try, if they can, to have 1 or 2 cups of coffee every day. Of course, coffee is not for every.
Great. And I think dosing and timing matters too, right? So you can, coffee in the morning, my typical recommendation is like, don't have any coffee after 12 because the half-life for some people is like as long as 6 hours. So you still sort of have like a blast radius of coffee. If you have something at like 1 or 2 o'clock, you still have a blast radius of some coffee in the system, 9, 10, sometimes 11 o'clock at night as well. So your points are very well taken. There's some other ones I'd love for you to expand on. So let's talk about alcohol. And then there's a couple of other items in the book that you outline that are absolutely within our control that can help to reverse, liver disease. So let's talk about alcohol. Let's start with alcohol.
In some ways, we've been a little bit tricked into thinking that alcohol is a healthy food. And I would even hesitate by referring to alcohol as a food at all. When we think about alcohol consumption, and we think about the serving size and what has been recommended to us by the American Heart Association, the CDC, and the World Health Organization, we tend to maybe think, okay, if I have a serving of alcohol every day, that's going to be good for me. It's going to help with my health. Now we're having a lot of research saying, maybe no alcohol is a better option for your health. And are we really having that serving? So number one, let's look at alcohol for what it is, and that's a toxin. Not only do we know that alcohol damages the liver, it also, especially in women, damages the heart. We also know that it increases the risk of breast cancer. So we can look at, we can really look peeling the onion away and looking at what are all the things that impedes our sleep. So even though it's a sedative and it helps us fall asleep, it definitely doesn't help us to stay asleep. And when I tell my patients, again, as you could probably tell, Dr. Stephanie, I talk in a lot of analogies, but when the liver and the whole body senses alcohol, which is a toxin, all other things stop for the most part. That's why blood sugar goes up. And in some aspect, the liver is like, holy Moses, I got to convert this into something that is tolerable, and then I got to get it out. And while I'm doing that, I can't deal with managing your blood sugar and all that. That we're going to have to put that off to the side. So once it does do that job, it's like you're going to wake up 2 or 3 in the morning, and you're not going to be able to get back to bed. So it really does inhibit sleep. It is not something that's good for sleep. There's some argument that resveratrol and red wine, and people say to me like, hey, well, what about the blue zones? They have alcohol in the blue zones, and it's really healthy. They also do a lot of different things in the blue zones that we don't do. So it's just there's other aspects that are going along. So I would say, if you have fatty liver, trying to limit alcohol as much as possible is going to be really, really, really good. And the other thing too is that when we drink, and women, as you know, get drunk earlier than men, easier than men, because of the difference in our body composition, water, and then certain hormones that break down alcohol. So when we drink and our goal was, I'm going to eat healthy tonight, the minute we become a little drunk, that goes out the window. All of a sudden, we're ordering dessert. So there's a lot of factors that go into it. We could have a whole podcast on that. But alcohol, limiting that, I think, is key. I think that's a key factor. And it quite frankly, we know it's going to help you drop weight. So I think that's a huge factor.
I think the amount of resveratrol that you get from the amount of alcohol that you would have to consume to get a clinically significant dose of resveratrol nulls the other things that you were saying, the toxins and the necessity of the liver to now stop all of these other functions that it does in the body in order to metabolize and create intermediates of the alcohol to get to prepare it for expulsion. I think that negates any benefit that you're going to get from the resveratrol. Yep. I mean, you can just have some green tea. You can find a supplement. I think that we can, and I think this has sort of been overblown a little bit with the French paradox and all. It's like, the French and the blue zones, to your point, they have community, they walk after dinner, they're doing all, there's so much, they have different attitudes towards work, different stress management techniques. Like there's so many different things in these blue zones, so to speak, versus like a North American typical North American or Western, someone who's living in the Western world, I think maybe more accurately, that we can just do away with alcohol. And to your point, we can have an entire conversation around the culture of alcohol and how it's so ingrained and all these different things. So, okay, so alcohol we can get rid of. Dr. Hanouneh mentioned coffee. What are some other things that we might think about in terms of consuming like foods that are going to upregulate liver health?
Extra virgin olive oil is one that I recommend to my patients a lot. I mean, there's so many studies looking at the polyphenol content of extra virgin olive oil. I think the challenge here is, how do you find an olive oil that's not tainted, that is pure? And that can really be the challenge for the average consumer, right? And you can look at all the different aspects of what makes a good olive oil versus a bad olive oil. So there's kind of that conversation. But if we just look at pure first pressing, cold press olive oil, we know that the benefits to liver health have been shown in studies to help reduce the overall inflammation. And so I tell my patients, I actually did an Instagram post on this, and it was interesting. It was like, I had so many comments on this one, like, oh, I tried this and it wasn't that bad. If we look at the studies looking at overall mortality, reduction of mortality from cancers, heart disease, neurodegenerative diseases, it looks to be about half a tablespoon to 3 tablespoons of extra virgin olive oil a day from the data seems to be the sweet spot. So I tell my patients, you know what, if you can't figure out a way to get that in, just put it in a little shot glass and down it. Just down it. Right? Just down it. So I think extra virgin olive oil is a really good one. Green tea that you mentioned is another one. I think color in general. A lot of my patients will say, oh, I don't have time, or I don't even know how to get 7 to 8 servings of fruits and vegetables a day. Who has the time? And so instead of talking about servings, let's talk about colors. Can you get 7 colors in today? Can you get 7 different colors in? So deeply hued berries. The more color we get, the more variety, the better our microbiome is going to be. We have data on this. So deeply hued things like that, beans and legumes. So looking at what are some of the plant-based proteins that we can consume. Not to say that animal-based proteins aren't good if we're choosing the right ones, but where can we get some really good quality plant-based proteins? My patients, again, probably at least once a week are asking me, what about some of these burgers that are made from plants but are made to taste like meat? Should I just have the real thing? All right. So I get that question a lot. Should I just have a cheeseburger or should I have an Impossible Burger? Which one's better? So, those are all things to look at. Like, where are we getting plants from our diet? Where's the color coming from? Where's the fiber coming from? But all of those aspects that we see in plants will be protective towards inflammation in liver health. The Mediterranean diet has been shown to reverse fibrosis in the liver. So I would say if we're going to kind of package it, the Mediterranean diet is probably going to be your best approach.
And you mentioned chocolate, and as a woman, I feel obligated to ask this question. It's like, how is chocolate beneficial, Dr. Hanouneh? Maybe you can answer this for us. And what should we be looking for in the chocolate? I'm assuming it's not not to mention any, but I'm sure it's not a caramel bar. I'm sure it's not. What are we looking for when we're trying to find chocolate to add into our diet? And what are some of the benefits that chocolate has?
Well, yeah, I got bad news. It's not milk chocolate. It's the dark chocolate. Dark chocolate that would be, if you will, beneficial somewhat in some studies to fatty liver disease. Dark chocolate, obviously, it's another topic, but pay attention to 70% would be, because I think according to the FDA, it doesn't have to be 70% to be called dark chocolate. Kristin can help me with that, but you might want to have at least 70%. The mechanism is poorly understood, quite frankly, but it's number one, it's anti-inflammatory. Number two, it improves insulin resistance. Once again, too much of a good things can be a bad things. So in moderation, I love my chocolate myself, but I try not to eat chocolate every day. And when I have chocolate, in moderation, that's kind of, the quick snapshot of the relationship between coffee and fatty liver disease.
I actually like to combine the two. I like to have a chocolate with my coffee.
Okay.
So it functions as a nice pre-workout for me sometimes. Like I'll just have like a square of chocolate with my espresso in the morning, and it's just lovely. And sometimes I'll even just melt it. I'll just put it in the espresso itself. But once it's just one square, right? So it's usually like 80%, 85%. And they come in sort of like a nice square size, and I take one square, and then that's, that goes well with my espresso in the morning. And then that's just my energy for sometimes when I don't have time to make any food before my workout. That's what I'll have. Okay, so let's maybe maybe wrapping this up, let's say. The last question, so we've been talking a little bit about things that are within our control, foods that are really helpful for our liver. One of the, and I'll say, ways that we necessarily don't have control, certainly we've been talking a little bit about age, we've been talking about the perimenopausal and menopausal transition. We've talked about age, if you're a young child and you've had sort of this metabolic disease for a long period of time, it's going to have you're going to have a longer delta where it can kind of solidify and create some of the cirrhosing and the scarring in the liver. There was one that I wanted to come back to, which was, and I believe, Kristin, you mentioned this, or it might have been Dr. Hanouneh, I apologize. One of you mentioned what your mother, the health of your mother in utero. And I just wanted to come back to that because I wasn't sure if that was that, is that like something that's genetic? Is that, gestational, if mom had gestational diabetes, is that putting us at a higher risk for fatty liver?
Sure. Yeah, we did find some studies looking at gestational diabetes and fatty liver of pregnant women. And what we found in the data is that if your mom had either of these things, so you could have both, or you most likely had, one or the other, your mom did, then you were much more at risk to develop that later in life. So once you got into your adult years, you just had the genetics to make you more prone to something like fatty liver versus someone whose mom did not have these things. And that was just based on a few studies, but we felt that it was a strong enough correlation to mention it because we have plenty of patients that are seeing us for fertility. They plan to get pregnant. And part of that plan is, okay, I need my PCOS to improve. I need all of these things to improve so that I can get pregnant and be as healthy as possible for that child. So that's why we included some of these studies here. But that's, again, where we would say, let's look at what everyone before you, what was associated with them in terms of your own individual risk. Even if your numbers are fine, even if your waist circumference is fine, that genetic risk is so important.
I would also say too, and I would love for either of you to comment on this as well. So if on one end of the continuum we have gestational diabetes, and that can influence it, I would almost, and I'm thinking of, and I can't remember the war, but it was in the Netherlands. It was during the Second World War, and I remember, and my son who's 13, who knows everything about World War II, is going to be shocked that I can't remember the name of this war because we've talked about it so many times. But there was something that happened, and then the Nazis basically bombed the food coming into the Netherlands. And so there was this big mass starvation that happened. So the women that were pregnant at the time, what they found was those children, once they were born, also were very obese, right? So they had turned on in utero, like when the mom was really starving, so she didn't have enough substrate. The babies in utero exposed to that stressor then went on to become, like, they had a much higher percentage of being obese. So you mentioned the GD, with maybe excess, or maybe maybe there could be some genetic component there as well. And the opposite is also true. If mom's not eating enough, that might also, and either of you, I'd love for either of you to sort of, if you know what I'm talking about, I think it's called the White War, but I'm going to fact check myself on it, where these Dutch women didn't have enough food and they were essentially starving. The baby, and they hopefully survived, but those babies that were in utero during that time went on to become obese.
Yeah, there are actually several genes that have been isolated now in association with fatty liver disease. There are actually bad genes that make someone susceptible to develop fatty liver disease, and there are good genes that will protect you from fatty liver disease. And those genes are not enough by themselves to give someone fatty liver disease. They got turned on and turned off, if you will, by certain factors, like the environmental factors you mentioned, the, starvation, the lack of food, certain diets, those kind of things in the right setting, in the right genetic makeup, but put someone at increased risk of fatty liver disease. With that being said, it turns out there are certain demographics are more susceptible to fatty liver disease. So if you ask me about the genes that are associated with increased risk, they're common in Hispanic, for example. And they're common, although the Middle Eastern population is not well studied, but they are common apparently in some small studies in the Middle Eastern population. And it turns out those genes are associated with weight gain around the belly, like the visceral obesity, if they will. And, we talked earlier about the waist circumference, and relationship with fatty liver. So I guess the short answer is that, it's all about genes, but genes are not enough to give someone a fatty liver disease. They got turned on or off based on some environmental factors.
Great. And I think, at the time of this recording anyway, there's no real pill. I mean, certainly we can think about the GLP-1 agonists and things as a tool to reduce, obesity. But in terms of fatty liver disease in and of itself, there's no direct targeted medical or pharmacology, at least that I'm aware of. This really can be something that we can reduce through, pulling some of the levers that we've talked about today with diet, with movement and exercise, with some of the foods that we've talked about, the coffee, the berries, the dark chocolate, and so forth. And you outline, there's 12 foods that you outline in the book with all of their functions as well. So I guess my last question for each of you in terms of, what you're seeing clinically, what are some of the things that you personally are integrating into your own lives as a prophylactic, we'll say, towards, preventing the development of fatty liver disease?
Yeah, I think as a woman in menopause, I'm really trying to optimize sleep. And I really appreciated everything you said, Dr. Stephanie, about resistance training and weight training. I have patients say to me, if I only have 30 minutes, should I do aerobic or weights? And my answer has changed now that I am in the stage that I am in. It's always weights. So I think trying to maintain as much muscle as possible and making sure we're having as much antioxidants as possible. I think that's a key for women as we get older. We need to protect our body. And it's not just going to happen naturally like it did when we were in our 20s, right? So we have to kind of look at how do we not only live longer, but live better, which obviously is going to be health span. So my whole goal is really looking at my health span and then integrating, what are the what did come before me, right? So we've had all this conversation has been about fatty liver. In my family, I also had dementia in my family. So I'm going to look at, okay, what can I do to prevent that? But I'm also going to look at what are the factors related to dementia that I might be genetically at risk for. So again, it speaks to the personalized approach to nutrition. There's not that one size fits all. We could probably find something that can help really heal all of the organs that we're trying to make better, to make work better for us.
Beautifully said. And what about you, Dr. Hanouneh? What are some of the things, either in the process of learning about this book, in your own clinical practice, that you've seen in patients that you integrate into your personal life?
I always learn from my patients, quite honestly. I feel like, every time, I listen to I've been told by my mentors before, listen to your patient, they're telling you something that you're gonna, it's very common. I always think about fatty liver every time I see my patients. 1 in 4 people have fatty liver. Number 2, it's a silent disease and can be fixed and reversed early on. My patients, 1 in 4 people have fatty liver. Number 2, it's a silent disease and can be fixed and reversed early on. So it's all about early detection. If you find it early, you can reverse it. And number 3, a wise man once said, let the food be your medicine. It's all about early detection. If you find it early, you can reverse it. And number 3, a wise man once said, let the food be your medicine and you can get that disease fixed. That's technically the take-home message, I guess, with the fatty liver.
Yeah, patients are always our greatest teachers. That's one thing I was very humbled to learn in my time in private practice as well. I want to thank both of you for your time and your focus today. I think this is going to be such a needle mover for our perimenopausal women that listen to the show. Thank you both so much for your time today.
Thank you. It was a privilege.